Good morning. My name is Joella Butler, and this morning I will be talking about tetanus. Tetanus is caused by the bacterium Clostridium tetani, which is a gram-positive bacillus, obligate anaerobe, motile, and readily produces endospores, which are resistant to desiccation, disinfectant, and heat. You can boil it for up to 20 minutes. You can see in this endospore stain the little green endospores. Tetanus is widespread in the feces of domestic animals as well as humans, but it's simply not harmful when in the digestive tract. Those spores are very abundant in soil, and the endospores can persist for years. Tetanus is especially widespread in underdeveloped or economically challenged communities, which have poor hygiene or poor waste disposal, and very little access to wound care. The infection usually follows a deep penetrating wound, which will facilitate anaerobic growth. But the bacteria can also be introduced in medical procedures, with IV drug use, as well as after frostbite or burn, and even in chronic wounds. The incubation period for tetanus is usually about a week, but it can be shorter if the infection is more severe. Upon germination, the bacteria release two toxins, the first being tetanolysin, which really has no recognized pathologic activity, and the second being tetanolysin, the second being tetanospasmin, which is responsible for clinical manifestations that we associate with tetanus. The second toxin is one of the most lethal known to man, with a lethal dose of just 2.5 nanograms per kilogram. And to put this in perspective, the lethal dose of arsenic would be 200 million nanograms per kilogram. Once introduced into the body, the toxin uses axonal transport to infect motor neurons and eventually reach the spinal cord. Once it reaches the central nervous system, it enters central inhibiting neurons and results in a loss of CNS inhibition. Once the toxin binds to the neurons, it cannot be neutralized, so recovery of function requires completely new growth. There are 4 forms of tetanus, the first being neonatal, which usually results from umbilical cord contamination during an unsanitary delivery, as well as the mother not being immunized. You can see this baby here has the contractures that we associate with tetanus. The second form is localized, which is just in a specific target muscle group, and this occurs really when the toxin just doesn't have a chance to reach the central nervous system and spread. The third form is cephalic, which only affects the head. It can be introduced with an otitis media infection, a middle ear infection, as well as dental surgeries or head trauma. And you can see this child on the right has cephalic tetanus. The last and most common form is generalized, which comprises about 80% of cases and has a mortality rate of 40 to 60%, though it can be decreased by intensive care to around 20%. This last form develops when the toxin spreads through lymphatic fluid or blood to multiple nerve terminals and affects more than one area of the body. The signs and symptoms of tetanus include the hallmark of acute onset hypertonia or severe muscle contractions. This includes trismus or lockjaw, which we see on the older man in the middle, and you see that in around 75% of cases. It also includes nuchal rigidity or Nick's deafness, dysphagia or hydrophobia, which is inability to swallow, as well as rhesus sardonicus or the scornful smile, which you also kind of see on the old man. And it can also include high fever, diaphoresis, rapid heart rate, high blood pressure, and all the while the patient's sensory neurons are completely intact, so they're feeling severe pain. Some secondary complications can include fractures or tendon ruptures from all of these violent contractions. The diagnosis of tetanus is really just clinical. Any cerebral spinal fluid or blood counts will be unremarkable, and bacteriological findings won't tell you much because tetanus is so common in the environment. A patient that doesn't have a tetanus infection may still show tetanus bacteria. The really definitive test is called spatula test, which you place a spatula in the patient's mouth, and in a normal patient it will induce a gag reflex. But in a tetanus patient, their masseter muscles will contract over the spatula and they'll actually bite down on it, as you can see this baby doing. And that test will be positive in about 94% of all tetanus cases. The treatment for tetanus involves IV fluids and nutritional support because the patient can't swallow on their own. It also involves wound debridement to remove any additional endospores. You administer antimicrobials to stop further toxin production, and there is an antitoxin TIG, or tetanus immune globulin, which I'll talk more about later when I talk about vaccination, as well as ventilator support if the infection has progressed enough to affect the diaphragm and the patient's breathing. Pharmacologic muscle relaxers are effective in relaxing those violent spasms. The cause of death used to be asphyxiation, but now because we have mechanical breathing that we can manage their ventilation, the patients usually die of cardiac arrest. The vaccine was first discovered in 1924 and was used commonly in the U.S. military in World War II. But this original vaccine used bovine or equine serum to produce these antibodies, and people would have allergic reactions to them. So we developed a new vaccine in 1991, which is Tdap, and that's the vaccine we're still commonly using today. Human tetanus immune globulin, or HTIG, is considered the tetanus antitoxin. It's a human serum with activated antibodies, and that's what the initial vaccine is comprised of. And that can be administered prophylactically as a vaccine, can be administered following injury in patients who have had likely exposure, or if their vaccination is uncertain, or it even can be used to treat active cases of tetanus. But because the protective antibody levels fall with age, you really need to get a booster about every 10 years, which contains the deactivated tetanus toxoid. And once you get this toxoid, it will trigger further antibody response. Since introduction of the vaccine, incidence of the disease has decreased by 95%. Fatality rates have dropped from 91 to 30%, and the mortality for those with at least a primary dose of the vaccine is only 6%. There are now only about 50 cases reported in the U.S. each year, and although global prevalence is still 1,000 times greater than that. So we have this safe, effective vaccine. Why is there still recurrence of this disease? Most of it is negligence. The 2000 National Immunization Survey found that only 9% of children receive all recommended vaccines at the recommended ages. And by 2 years old, around 90% of children receive at least one vaccine outside the recommended age ranges. And factors that increase noncompliance are a large number of siblings, mothers that are younger than 25, a lack of insurance, and multiple healthcare providers. It's also estimated that less than 60% of adults are vaccinated as recommended, just because they get complacent. There are also recently ideological objections. According to the CDC, 80% of pediatric cases in the past 20 years had no vaccine. And of these 80%, all cited religious or philosophic objections. There was also a shortage of the antitoxin in 2000 to 2002, which really just meant that people weren't encouraged to get their boosters on time. There were still administered prophylactic treatment when necessary after exposure. Thank you for your time. I hope you learned something.